Good evening, good afternoon. Thank you for joining us for today's International League Against Epilepsy Africa webinar. I'm Dr. Nalucha Mwendaweli. I'm a neurologist from Zambia. So for tonight's webinar, we're joined by Dr. Prakash Keithan. Dr. Keithan is a neurologist at the Wits-Donald Gordon Medical Center in Johannesburg, South Africa, and he'll be talking to us on the topic classification of epilepsy. So before he begins, just a few housekeeping rules. If you have any questions, please feel free to put them in the Q&A section, and your questions or comments will be answered at the end of the presentation. So for now, I welcome Dr. Prakash Keithan as he gives us our talk.
Thanks so much. Can you hear me?
Yes.
All right. So
yes, we can get you.
Thank you. So we are going to be dealing with the classification of epilepsy and seizures. Given that a new classification of seizures has come out this year, I thought it would be good to give everybody an update on the new classification of seizures. So I have focused the talk on that. We will also be dealing with the classification of epilepsy, and that is more from around 2022 and 2021. But a big focus of this talk will be on the new ILAE 2025 classification of seizures. So what we are going to do is we're going to introduce the classification, give some rationale behind it and why there was an update, because the previous update was in 2017, and there were reasons for an update. Some people do feel that the update is or was sooner than expected, but we will cover that. We'll cover the actual classification itself, and then, like I said, we'll go through the classification of epilepsy in terms of the different types and syndromes, and then finally, we'll look at the important additions and changes to the new classification and also the practical application. So this was the main article that I focused on because this is the article that highlighted or explained what this new classification is about. As you can see, it was revised in 2025, accepted on Valentine's Day, 2025. And then in terms of that, the commentary was given about a month later. So this the article on top, what is the latest of all the articles I read through about the ILAE classification, and then the lower article that is to do with epilepsy syndromes and the methodology for classifying them, and that was in 2022. And then the rest of the articles, the one has to do with the idiopathic generalized epilepsy syndromes. This is sort of part of the article we just covered. And then the upper article is also to do with, is also part of that update in the classification of of epilepsy and the epileptic syndromes. These articles are important, but I did not focus on them, and they will not really be covered or part of our talk, as I thought, since I'm an adult neurologist, I would focus mostly on that subject matter. So this talk is from the ILAE, and the classification is also from the ILAE. And I think it is important to understand that this is a global organization, and it is the biggest organization in the world, with epilepsy as its focus. And the idea is basically to help educate and help improve the treatment of epilepsy worldwide. As you can see, it has a long history from 1909, and these classification systems play an important role in understanding epilepsy, and then also thereby guiding us as clinicians in treating epilepsy. So in terms of the timeline of the classification of epilepsy and seizures, specifically seizures, we can see on the left of the screen. In 1964, it was the first classification was made, and then about 6 years later, it was revised. Following that, in 1981, further classification and revision was made. And then there was quite a large gap before further classifications. So, and then we can see at the end, it becomes fairly common to revise and to bring new classifications. And this is all to do with our understanding of epilepsy, to make it better for us in order to also treat the patients better. As we'll go through, the classification itself has to do with a common language, and that is the goal behind it. And what would be the focus that is what they intended. So this will be expanded on in the rationale, but essentially it is providing a framework, and that framework is important in terms of an understanding for us, and again, improving our communication. Understanding the complexity. Epilepsy can be complex, but if it has a system and it can be understood and everyone is understanding it in a similar way, it can enhance treatment referrals. It can make the treatment for a patient much better, especially where there are multiple people in the care of who's caring for the patient, and thereby tailored treatment approaches. So in terms of the rationale, it goes back to 2017, which was when the classification of seizures were last given. There was terminology fatigue, and I highlighted awareness versus consciousness. Awareness is more of a perception of amnesia, or the patient does not remember, whereas consciousness can be synonymous with that, and is more about the experience itself. And often this word awareness or this word consciousness is linked to the word impaired, because that's what we are talking about in a seizure. And impaired can mean all the way from not being conscious to having a spectrum of impaired consciousness, where someone is aware, but they still have an impaired consciousness. And later on, we'll see operationally the consciousness is divided into awareness and responsiveness. And that's the main point with what they were trying to achieve with the word consciousness. Then in 2017, they also had motor versus non-motor. And with the revision, that has been updated to being observable and non-observable. But it's basically because motor is the focus and it's not exactly accurate. And this is more especially noted in various other types of focal seizures where motor isn't the first manifestation in the semiology or how the seizure takes place. So that is why that change was made. Also, the 2017 classification had 63 types of seizures, and much of it could have been redundant. It was difficult. It wasn't a bad system in its entirety because it has many similarities to the current system, and the 2025 update or the 2025 classification isn't very different, but it's different in a better way that it makes it easier to understand, or there's less you don't have to think about remembering all 63 types of seizure types. So it made teaching and coding and all of that quite difficult. And in terms of the ictal evolution, that has to do with also what we were speaking about easier. And this seizure classification is better for the chronology of a seizure and how to describe it. We spoke about the collapse. As I also mentioned earlier, having this sort of unified language for various types of doctors to communicate with each other is very important for EEG techs, neurophysiologists, nurses, patients, and the clinicians all speaking the same language is just very helpful in order to have that sort of common language of what type of seizure is this, and instead of people speaking sort of different types of classification updates. Now, that will happen, practically speaking, when many of my patients see me. Some of them still mention or talk about grand mal or petit mal from previous classifications. So time ultimately will be the decider on that, if everyone is speaking the same classification or if there will be yet another classification or update. But I think we can leave that to time. But I think the goal or aspiration is worthy. Then in terms of training and reporting, all of that is along the same lines. Importantly, what was noticed when the various doctors got together to discuss this and the need for a change is that they noticed that certain languages, I think many European languages, they had difficulty with words like awareness, whereas consciousness was easier. So I can't exactly tell you what that difficulty is, but it was brought up as a cause for concern. So when the various people who are interested in epilepsy, epileptologists from around the world, I think they were a similar amount of men and women, and they were from various different countries. They got together and they had this process. I think it's called the Delphi process. And what happened was there were 7 rounds of meetings, and each round they would need like 2/3 of a majority to move forward. And I think there was that sort of each round would take place, and finally in the final round, well, everyone agreed on this current classification that we are dealing with. So as mentioned, this new classification helps to capture the chronology of the seizure. And there are classifiers and descriptors. Classifiers are what we are mainly talking about, and the descriptors are, you could say, unlimited, but the descriptors basically assist or flesh out what is the seizure, but the classifier is more of the system that we are going to go into. So consciousness, one of the classifiers, as we said, is operationally to do with awareness and responsiveness. And then the motor, non-motor axis that we mentioned earlier has been now replaced with observable and non-observable. So before we go into focal seizures, it is important to understand what a seizure is. A seizure is a synchronized neuronal discharge, and that can be in one part of the brain or throughout the whole brain. And epilepsy is basically a predisposition to seizures or a predisposition to recurrent unprovoked seizures. Now, going ahead with the definition of focal seizures, it's part of the first part when we were talking about the definition of seizures. It is only happening in a specific area of the brain, that synchronized neuronal discharge. Another important part of the or understanding of the word or definition of seizure is that that discharge or electrical or neuronal activity is that it is abnormal, because our brains have electrical activity, neuronal activity all the time, but a seizure is abnormal. So as mentioned, so that if a seizure happens in one part of the brain, it will then manifest with symptoms according to whichever part of the brain it affects. And therefore, in different parts of the brain, it would have the patient could have different symptoms. Now, most patients won't have, they'd have the same, usually constellation of symptoms with each seizure, but I mean, from patient to patient, that difference would be noted. And it is important to try and understand, based on the patient's history, where more or less, especially if there is a consideration of whether it is a generalized type of epilepsy or is it a focal seizure, focal epilepsy. Now, these are the various focal seizure types. There is the behavior arrest, and that's basically just sudden cessation of activity, freezing, or unresponsiveness. And that is something that is noted uh, in many types of epilepsy. And sometimes it's the first thing noticed. And it was one of the things that was not so, it wasn't covered so nicely in the 2017 classification. Then number 2 is automatisms. That's like these repetitive involuntary actions. The most characteristic and most common is lip smacking. Then you get clonic. That is the rhythmic jerking of the muscles. That can be unilateral because it's focal, or it could be one side of the body. It could just be one limb. And that the important thing there, which differentiates it from the next one, which is myoclonic, is that it's this continuous jerking, whereas myoclonic is brief, shock-like muscle jerks. It's not usually like these repetitive jerks, and it's more it's brief. It can happen around sleep, and that's how we mostly can understand about myoclonic, is that there is also a physiological myoclonus, and that we notice that when someone wakes us up or before we fall into sleep, we may get that like jerk-like movement. That is an example of myoclonus. So but in these myoclonic seizures look very similar, but they are epileptic, and we see the abnormality on EEG. Then you get tonic seizures, which is a sustained muscle stiffening, and and it can be postural. The whole body can be stiff, and it is like sort of connected to the clonic one earlier, because as we'll come to when we cover the generalized, they come together in the generalized tonic-clonic seizure. Then we get atonic. Atonic is the sudden loss of muscle tone, and this can lead to collapse. We call that collapse drop attacks, and this is the cause in this case would be epileptic in nature. Then we get epileptic spasms, and that's to do with short bursts of flexion extension. Now, these epileptic spasms are often more common in the pediatric epilepsies, and they are mentioned here in the focal seizure, but we'll also see it in generalized. It can be either, can be unknown, and it can also be applied to adults where if it is relevant. Then you get hyperkinetics. They call it chaotic and violent motor activity, resembling agitation. Although that doesn't quite help us to understand it exactly, because it could also be stereotyped like movement patterns that happen, like someone cycling or that type of thing. It's those kinds of bizarre movements could be also considered seizures. Then, in terms of sensory, various types of sensory sensations that are positive or active sensations from different parts of the brain, whether it's visual, auditory, tactile, are also experienced. Autonomic can be visceral, piloerection with the skin, nausea, tachycardia, bladder, various different types of autonomic seizures, and then cognitive, Someone can have an aphasia with language difficulty, memory, awareness, and then emotional in terms of sudden feelings of fear. I've seen patients who were referred for this kind of concern, whether they were having rage attacks or that type of thing. In terms of the 13th one, and the last of the focal seizure types, is focal to bilateral. This is very important because it helps us understand that not all generalized tonic-clonic seizures are generalized epilepsy or generalized seizure types. They can start focal and become generalized. So that's important. And for a seizure to be generalized, it's bilateral. It means both sides of the brain, which is what our next slide is about. Simultaneous bilateral brain involvement, as we said with the definition earlier about seizures, is it can be all neurons at the same time. So that's what generalized seizures are about. And it can be diverse, and we'll go through that next. Similarly, we did 13, and we still need to get to 21. So the generalized seizure types, first one is absence, and that is the typical type of seizure that people think about when patients or stare and they're not there, blanking out. Blinking is often associated, and then you get the tonic-clonic seizure, generalized seizure, and that's the one that I mentioned earlier. So this is probably the most common one and the main one that most people see as what a fit is or what convulsions are, is this tonic-clonic seizure. And then you have number 16 and number 18. You get different parts of that. Again, the clonic is mostly to do with the jerking of the patient. And then I'm just skipping myoclonic for now, but the 18 is to do with the tonic or stiffening. In generalized tonic-clonic seizures, both of them happen. Whereas in 16, it's just the clonic part, and in 18, it's just the tonic part. Then myoclonic, we've talked about earlier on, as we have also atonic. We've mentioned epileptic spasms, and then finally, negative myoclonus. Importantly, this seizure type is new and was not in the 2017 classification. And this is a brief pause in muscle tone. So I also noticed the similarity with negative myoclonus and atonic seizures. I think the distinction is not that stark or significant, but essentially the idea is that negative myoclonus is more like myoclonic seizures, that sort of brief 1 second or less, or just around that type of thing in terms of the loss of tone. Atonic is usually considered to be a little longer than that. So it could be more than that, maybe 2-3 seconds. In terms of atonic, maybe longer sometimes. So I think that is the distinction there. Then, so all of these are, I got these from the articles. And then this one is from the main article. this is the expanded version. There's also a basic version, but I thought to show the expanded version. And basically, it tells us a lot about the classification. So there, as we can see, there are 4 types in total. You get the focal, the generalized, the unknown, and the unclassified. And then, as you can see again, with the focal and unknown, they mention specifically about consciousness. As we'll talk about each one individually just now. And then in terms of generalized, they mention all the types of generalized seizures that we just spoke about. So those 4 types, they are part of what we call the classifiers. Then we also have additional information that we can add to the classification, and that is through the descriptors. And that's through the chronological explanation. Like, for example, if you have a seizure who first gets a feeling in their belly, and then gets olfactory hallucinations, or then gets lip smacking, and then it carries on in that way, then we would describe it exactly maybe how the patient describes it, or depending on if they have impaired consciousness and cannot describe it, what the witness, how they describe it. So there is more freedom in terms of the final seizure type, because you get the classification that we will give, but then you get this expanded descriptors, which gives more information and context in regarding the semiology of the patient, which will help again with localization when it's important, and also just an understanding of what type of seizure it is. And then this is similar. It's again with all the different types of seizures in giving it with the numbers. And then you have the different types here with the focal preserved consciousness, focal impaired consciousness, and then focal to bilateral tonic-clonic seizures. We mentioned about the descriptors, and then we move on to unknown. So we might as well cover it now. Unknown is more referring to whether it's focal or generalized. When we say unknown, that is what we are talking about. With unclassified, it is similar to that, but it's not exactly the same. I think let's cover that later. And then in generalized, I think we've been through most of this. I think we haven't gone through some of the absence seizures. So you get the typical absence seizure, which we chatted about. And then the atypical absence seizure, the absence is usually slower, and it's not a typical absence with like the characteristic blanking out. There's also more movement involved. And then you get myoclonic absence seizure. That's where the patient's arms sometimes elevate with the seizure, with basically a short burst or a brief myoclonic jerk with the absence. And then you get eyelid myoclonia. That's to do with just myoclonus of the eyelid associated with seizure, and specifically with the absence seizure. And then you get absence to tonic-clonic seizure and myoclonic to tonic-clonic. So myoclonic to tonic-clonic is basically the same myoclonic jerks happening more frequently, eventually going straight into a generalized tonic-clonic seizure. So as we mentioned about unknown seizures, the main concern with it is whether or not it is focal or it is generalized. This is the one I said I'll leave for later, and later is now. So I don't want to confuse anyone when I say it is the true unknown, but what I'm trying to say, or what I'm trying to express with that, is that whereas the unknown seizure type is where typically we don't have all the information. We see the patient, only the patient. We have no access to collateral or video or any other information. And we, based on clinical impressions, we call the generalized tonic-clonic seizure, or we call it an unknown seizure to generalized tonic-clonic seizure, because we don't know if there's a focal onset, or we don't know if it's generalized, if it is a generalized seizure on its own. So that is what unknown is about. Now with unclassified, and then that can be revised later on. If you get collateral, if you get video EEG, you can then revise it and see, okay, no, it's starting focal seizure becoming generalized, or bilateral tonic-clonic seizure. So the unclassified seizure is when essentially we have all the information, or as much information. We have EEG, we have the history, but we still cannot say. It's difficult, either from the history. Often this difficulty is noted in rare genetic disorders, metabolic disorders, or neurodegenerative disorders. And investigation doesn't help. I think it's important to flag in certain diseases for future investigation about the pathology. But I think what all of this, the fact that there's one unknown type and then there's one unclassified type, I think it is important, because it tells us that I think there's something to be said when you admit that you don't know. And I think that this classification is more along those lines. If you don't know, it's better to say that and move forward, instead of just saying it is this. And I think we can say unknown seizure, but suspected to be focal, or that, as we know that we can add various descriptors. That's not part of the descriptors, but that's for our own understanding of a case in epilepsy. So in terms of the epilepsy types, the importance here is that these are, as we said, what epilepsy is, the recurrent unprovoked seizures. So it's just an expansion of that. And to have a seizure type, then an epilepsy type, and then eventually to get to a syndromic diagnosis is the goal in patients with epilepsy. So again, it's just expanding on, so focal epilepsy is expanding on focal seizures, and similarly, generalized epilepsy is expanding on generalized seizures. Then we get the combined generalized and focal seizures. And this is with people with both types of epilepsy. And then again, unknown. And I put onset in brackets, and that's mainly to clarify again, the unknown part is whether it is focal or generalized. Then moving on, we also looked at this one, which I showed you earlier, which is the methodology for the classification. And then the key points about epilepsy syndromes is that this is the definition from the article, is that an epilepsy syndrome is a characteristic cluster of clinical and EEG features, often supported by specific etiological findings. So the key words, the key words would be clinical, EEG, and etiology. And this type of syndrome is also called like an electroclinical syndrome in terms of the importance of EEG. And the clinical, it would be to do with the history and examination, and the etiology would be to do with the cause, like whether it's metabolic, structural, genetic, immune mediated, or a combination. Then in terms of the diagnosis of epilepsy, once we have that diagnosis, then we can start to give the patient more answers in terms of treating them and in terms of prognosticating them. There's a mention about the age, and that's essential in terms of these, in terms of getting to a syndrome, because as we'll see later, at different ages, certain different types of epilepsies can happen. And then they divide it into 4 groups. So this, you can see one of the new things for the 2025 classification is the elimination of the word onset. So what we see here in these 4 is still from the 2017 classification, and that's because this was in 2021, 2022. So that's why it's still kept on the onset, but for us to know the 2025, and I'm sure this article will also then be updated at a later point with from the 2025 update of the classification of seizures. I think various other updates will happen as a result. And I think we've covered that. And then, so the first 3, I think we can all understand. And then in terms of the 4th one, the developmental and or epileptic encephalopathies or progressive neurological deterioration. So these are with patients, this is usually in the pediatric epilepsy, and it's usually patients with cognitive impairment, and that may develop with time. That's the developmental part, and that's developmental is specifically relating to the cognitive impairment. And then the epileptic encephalopathy, which also has to do with cognitive impairment, but more specifically relating to the epilepsy aspect of these types of patients. And they can be also grouped together like this. And then the need, this is again now the need for the epilepsy classification, not the seizure classification that we were talking about earlier. And it's the same type of thing, getting that sort of language for everyone. So everyone's understanding the same type of thing, what's happening with a patient, what the diagnosis is. And the idea behind it was to get criteria for the syndrome diagnosis, and how they divided it, and we won't go into detail about it, is mandatory, and I think I mentioned it, yeah. So there's mandatory, exclusionary criteria, and alerts. So mandatory criteria is essential to the diagnosis. These are specific hallmarks to the epilepsy syndrome. Exclusionary criteria is basically when certain things are present, the type of syndrome that is being thought about cannot be diagnosed if something is present. For example, later on, we're going to be dealing with idiopathic generalized epilepsies. And some of them you could be having a cognitive impairment. But if someone has significant cognitive impairment, it's considered an exclusionary criteria. Whereas mild cognitive impairment or mild cognitive symptoms would be just considered the third point as an alert that you should basically, if someone has an alert, it's to make a mental note that this might not be what I'm thinking because this is pointing against it. So that's the sort of consensus on how or the criteria. And then this was also similarly achieved with the multi-round Delphi surveys. I like the name, the Delphi from the Oracle of Delphi, but I think that's probably where they got it from. Then in terms of the framework on how to get to the syndromes, what they wanted, their goal for this classification was to get to etiology specific syndromes that can be achieved in certain cases and sometimes it can't be achieved, but to get as close as possible to that. But in general, an approach was needed, and then they gave 4 axes in order to get to a syndrome. Importantly, an age of onset and a sort of a range of age where these types of, or whichever type of epilepsy is happening. You get core seizure types, and that was originally guided from the 2017 classification, but we could understand it with the 2025 ILAE classification. And then the EEG, what is the characteristic pattern, and etiology or genetics when known. Etiology could also refer to the imaging in terms of the brain, if there's a tumor, trauma, neurocysticercosis, that type of thing. And then I thought these pictures were really good. So these all these pictures are from that same article, the methodology. So I invite all of you to take a look at that. And as you can see, from neonate to infant, to child, to adolescent, and then we have the different types of epilepsy at different age groups. Importantly, we won't go through all of these, but from this page, the mesial temporal lobe epilepsy with hippocampal sclerosis, so that gives like the TLE type patients. And I thought it's an important point to mention. Another part of the update, and this is in 2021, 2022, is they changed certain types of names, whereas it was previously like benign. All of these self-limited epilepsies were all called benign. They changed the name now to self-limited. I think this first one used to be called the benign Rolandic epilepsy with centrotemporal spikes, or it was just called Rolandic epilepsy, and then they came with the centrotemporal spikes epilepsy after that. So the classification and naming has evolved over the years. This one here, the hyperkinetic epilepsy or sleep-related hypermotor, that's like the nocturnal, it used to be called the frontal, yeah, anyway, I forgot it already. So And then you have the different types of occipital epilepsies, and as we see at the bottom, epilepsy with auditory features, and that's a type of focal epilepsy with auditory auditory symptoms, and it's from the temporal lobe. Then we have the generalized epilepsy syndromes. So these were all the focal, and these are the generalized. And at different ages, again, different types of epilepsies are seen. We will cover a lot of these just now, but so the ones that we want would be the epilepsy with eyelid myoclonia, and then this type of epilepsy is associated with these seizures, and it can also produce generalized tonic-clonic seizures, can produce cognitive symptoms as well. And this is to do with the eyelid myoclonus. So this is especially induced when the eyes are closed and can be photosensitive. And then you get the epilepsy with myoclonic absences. We mentioned about the seizure type of myoclonic absences earlier, and then this is the epilepsy where that's from. Then myoclonic epilepsy in infancy, I think that's a benign type of epilepsy, and then these are like mixed seizure types. The epilepsy with reading-induced seizures also has a relationship to myoclonus, but it's more specific with reading. In terms of that, and there's also another type called reflex seizures, but it hasn't been incorporated into the syndromes. And then this again is like the pediatric epilepsies, and especially to do with the developmental and epileptic encephalopathy. And they have different types here. Some of them here are genetic, and some of them are acquired. So we see the Lennox-Gastaut syndrome, which is well known as this very difficult to treat epilepsies of different seizure types and different causes. You get the Rasmussen's syndrome with the sort of like hemiatrophy of the brain, thought to be immune mediated, and then you get the progressive myoclonic epilepsies. It's important to know about this because we are going to deal with juvenile myoclonic epilepsy later, and this is important to know, especially in the setting of cognitive impairment. So also covered this paper. So they wanted to make a different paper specifically for idiopathic generalized epilepsies. I think in the 2017 paper as well, they took away idiopathic. Now, us as doctors, we have a long history with this word idiopathic, and it's we use it when we don't know. So we call things idiopathic, and they moved away from it in 2017 because it is presumed that all generalized seizures are of a genetic origin. So it was actually called, and all of them still are part of this, an idiopathic generalized epilepsy, you could say, is under this classification as what is called a genetic generalized epilepsy. But now idiopathic is back, and they've only included 4 types. And I think it's important that they've included these types because we'll see that they all have certain things in common. The main thing about them is that they all have a favorable prognosis, and the 3 of them have similarities, but more importantly have overlap, meaning a patient who had childhood absence epilepsy could get juvenile absence epilepsy, or could get juvenile myoclonic epilepsy. And also importantly about all of these is that they all may have learning disabilities and or ADHD. Their EEG is mostly similar as well, generalized 2.5 to 5.5 spike and wave discharges. Some of them, the one, juvenile myoclonic epilepsy, specifically more with polyspikes, but the others can have it as well. And then they all have normal neuroimaging, and it's likely polygenic inheritance. This is important because the part of the reason why they introduced idiopathic is because of stigma. To call something a genetic generalized epilepsy for patients may not always be best, because there could be stigma with the word genetic, and the idea of a polygenic inheritance could even be a spontaneous mutation, or it's difficult to say exactly what it is, but twin studies have confirmed that it likely is genetic, because the twin studies reveal that most people, their twin, will also get epilepsy in similar type or same type. But for example, their children may not get it, their parents may not have it, or their grandparents. So it's difficult to exactly predict from a genetic point of view. So it doesn't really help us all that much. It doesn't really help the patient either. So that's part of the reason why idiopathic returned. Then childhood absence epilepsy, typically between 4 and 8 years, but there is a longer range, as mentioned, and frequent absence seizures, 10 to 100 a day. We've been through absence seizures, but this is the characteristic types: sudden searing, eyelid flutter, unresponsiveness, examination normal. The EEG is typically 3 hertz, as we know, characteristics 3 hertz spike and wave, and provoked by hyperventilation. Again, with this type, in a resource-limited setting without EEG or other investigations, can simply be diagnosed like this, just with hyperventilation. And then you sometimes get the occipital, intermittent, rhythmic delta activity in 21 to 30%. And then you can sometimes get polyspikes, but importantly, it's only during sleep and drowsiness, not during wakefulness. If it was, then we would be considering something else. And then the treatment would be geared towards treating it. So it would be ethosuximide or valproate as the mainstays in terms of treatment. And importantly, it usually improves. I think this used to also have benign in it, if I remember correctly. And then you get the juvenile absence epilepsy. Age of onset is between 10 and 17 years. And there's 2 different seizure types that happen in this. You get the absence seizures and the generalized tonic-clonic seizures. And then in terms of the EEG, 3 to 4 hertz spike and wave, distinct from the childhood absence epilepsy. There was no OIDA, and treatment is with broad spectrum anti-seizure medication. Lower remission rates can persist, or in many cases persist, to requiring long-term treatment into adulthood. Juvenile myoclonic epilepsy. Importantly, so with the idiopathic generalized epilepsies, the reason why they were separate, one of the other reasons was that they were one of the most common types of epilepsy. This one is the most common type, being one of the most common types of epilepsy, most common types of generalized epilepsy. So 9.3% of all epilepsies, and that's all epilepsies, but that number might not reflect our populations in Africa. The age of onset between 10 and 24, usually morning myoclonic jerks, although it doesn't have to be in the morning, generalized tonic-clonic seizures, and sometimes absence seizures. You get the 4 to 5.5 poly spike and wave, and the anti-seizure medication is valproate or levetiracetam. Importantly, on this, certain other types of medications should be looked at or should maybe not be chosen. Things like Tegretol. Lamotrigine can sometimes aggravate the myoclonus, but it's not, it's still recommended for this type of epilepsy, and lifelong treatment's usually needed, but patients do well, and they do well with the treatment. Then you get the epilepsy with generalized tonic-clonic seizures alone. Alone is the word of interest, because I think, or I understand, it used to be, or it was awakening before, but they changed it, since it doesn't always happen, but it's still one of the hallmarks with this type of syndrome. So age of onset between 10 and 25 years, and generalized spike and wave or polyspike patterns. Broad spectrum anti-seizure medication, and also, again, just like with all of these, drug responsive, but this seizure is very infrequent, sometimes once a year or not even that. This helps us understand the genetic generalized epilepsies. So we have on the one side, the left side, we have the idiopathic generalized epilepsies, large group, and we've spoken about it. As we can see, we have the childhood absence epilepsy, juvenile absence epilepsy, juvenile myoclonic epilepsy, all connected together, and we've spoken about that connection. And then in the one corner, we have the epilepsy with generalized tonic-clonic seizures alone. And then on the right side, this is to do with the developmental encephalopathy, epileptic encephalopathy. And then we can see that there's the spectrum that they're trying to show us in the diagram, with epilepsy with myoclonic atonic seizures. I think that used to be called the Douce syndrome. And then you have the epilepsy with eyelid myoclonia. I think that's the Jeevan syndrome. And then epilepsy with myoclonic absences, and then the one we spoke about earlier, the myoclonic epilepsy in infancy. And I think the main point of this diagram, and quite helpful, is seeing that there's the spectrum with developmental and epileptic encephalopathy. Sometimes it would be very difficult to understand which is which, and certain patients, it's more the developmental aspect, and that when we talk about that, we're talking more about the cognitive. And with the epileptic encephalopathy, again, it's similar. There is cognitive, but we're talking more about the seizures. The patients with the epileptic encephalopathy can see an improvement if their epilepsy is better treated, but their cognitive impairment will not resolve, but they will be better. Whereas if there's in the developmental, it's more to do with the actual cognitive impairment. Then now these are the important additions or the main changes. I just wanted to make sure that everyone got sort of a grip on this 2025 classification, and these are the main changes. So they removed onset, as we mentioned earlier. Then they also talked about the classifiers and descriptors, which we mentioned also. The awareness with consciousness. We discussed that. And then the non-motor to motor to observable versus non-observable. And then the importance, or highlighting the importance of this complete chronological description. And finally, the addition of epileptic negative myoclonus as a classified seizure type. And then neonatal seizures were not taken into account with that article, and it was we did not cover it, and it was in another paper. So I thought it was good to just have an example. So this example is from the same paper, which is the first paper. A young woman awakens to find her 20-year-old boyfriend having a seizure in bed. The onset is not witnessed, but she is able to describe bilateral stiffening followed by bilateral shaking. EEG and magnetic resonance imaging are normal. The seizure is classified as bilateral tonic-clonic seizure, and so it's unknown whether it's focal or generalized. So this would be the unknown bilateral tonic-clonic. But in an alternative scenario, the EEG shows right parietal slow wave focus, and the MRI shows a right parietal region of cortical dysplasia. In this circumstance, the seizure is classified as focal to bilateral tonic-clonic seizures. So I think they highlighted this. It's like basically out of the book kind of example to just explain easily for us to understand the utility of this kind of system. And besides this example, there were other examples mentioned in the same paper, which you can go through. In terms of, these are some websites and of interest to us who are interested in epilepsy, the ILAE website. Then we get this very, it's an amazing website, epilepsydiagnosis.org. So it's basically an encyclopedia of epilepsies, of similar to what we described, all the different syndromes. And in case we didn't understand anything or you're uncertain about it, this website is also created by the ILAE. But an important note about it is that all the seizure types or epilepsy types mentioned in it is according currently, as of me speaking on the 1st of July, 2025, it's currently still according to the 2017 2017 classification of seizures. But it's still excellent. And I think as long as we understand the classification of seizures, we can apply it to that website. Then epilepsy.com, the various tools and resources that you can find there, and there's certain things you can print out, give to patients or patients' families for further information. And Epilepsia, I think I didn't on that website that the wiley.com online library, that's Epilepsy, I didn't find anything that needed extra payment or anything. So I thought that was good. And then we get the EpiGAD website, and that's with various genetic types of epilepsy, and especially there's a significant feature of pharmacogenetics. In terms of certain genetic types are treated by different medications better than others, like that. So the conclusion is that the new 2025 guidelines, they do make the classification easier. I think once we understand it and get our head around it, we can understand the classification in an easier way than the 2017 classification. And the whole idea is just to get that common language of epilepsy, and based on the meetings they had with the different people with different language backgrounds, it is better with this one internationally than with the 2017 paper. Then in terms of getting to an epilepsy syndrome classification or diagnosis, the idea is to become more specific, to get an etiology as best as we can with the information we have. And then finally, idiopathic generalized epilepsies are back, but I think the important word there, the idiopathic, and it just goes to our understanding of what about that, I think also to do with humility and understanding that sometimes we don't know. Thank you very much.